My talk is going to be about IOL exchange. I have no financial interest with to any of the product in the lecture. So the first thing to be asked before you go through the IOL exchange is why do we need to exchange the IOL? Is it due to an intraoperative problem to the lens, haptic damage or cut in which the lens is unstable inside the bag, or there's a crack in the optics of the IOL which will cause the IOL to be unclear? Or is it a post-operative problem in which you have a wrong IOL calculation, or if you have an unhappy patient, and usually these patients are the patient with a premium type of IOL in which their expectation exceeds the results and they are asking for other solutions. Before we go further, we should know that any additional surgical procedure, such as an IOL exchange, has a higher risk than the original surgery. So it is better to avoid or to prevent doing such surgeries. They can cause posterior capsule rupture, dehiscence of the zonules, and also unstable bag. Other problem is the corneal decompensation due to multiple procedures which will affect the corneal endothelium, and also finally macular edema may happen in these patients. So it is always wise to think of other solution. Can we fit the patient with the glasses or contact lens? Can we implant an add-on like a Sulcoflex or other IOL which can be implanted in the sulcus in a pseudophakic patient? Or can we do only a corneal refractive surgery rather than exchanging the IOL? If we left with the IOL exchange, how would we exchange the IOL? So till now, there is no optimum surgical technique to exchange the IOL. You can fold it, you can cut it in two halves, you can partially cut it, or you can enlarge your wound and externalize the whole IOL. It all depends on your type of IOL that you are dealing with, the instrumentation you are having, and your own surgical experience. Before you go to the surgery, you should have a good local anesthesia to the patient because there is some manipulation at this patient. Have a very good dilatation and be prepared with an IOL calculation and different type of IOLs because you never know what would happen inside the surgery. You may implant an IOL in the sulcus, you may fixate it to the sclera or to the iris, so you should be prepared in different scenarios. Lastly, you should know your instrumentation. Are you going to cut the IOL inside the bag? Are you needing the microsurgical technology instrument? Do you need a special lens cutter for non-foldable IOL? And second instrument to counter pressure your IOL. So here I have different examples. So this patient, post-phaco with the wrong IOL calculation, the first thing to be done, this is a thickness IOL, is just to release the IOL from any adhesion. So you should inject the viscoelastic material under the IOL and between the IOL and the anterior capsule, and then carefully and gently try to manipulate the IOL into the sulcus, taking care that you should not harm the capsule or the bag or the zonules. And if you notice any adhesion, you should stop and don't manipulate much in these cases. After manipulating the IOL into the anterior chamber, you should inject viscoelastic in front of the IOL to protect the endothelium, and then you should inject under the IOL to protect the bag. After that, you can use, here I'm using the lens cutter, which is a bulky instrument, and then you have to counter pressure the lens cutter using a second instrument. Is it a Sinskey or Coughlin hook or a second instrument to advance the lens cutter till you reach a point where you cut the IOL into two halves. Then you can externalize each half from a 2.2 to 2.4 millimeter incision. And after explanting the IOL, you should inspect your bag and your capsule, and if you are sure that there is no compromise to the bag or the capsule, you can just inject your replaced IOL, and then you can conclude the case. Other example of this case, this patient status post toric trifocal IOL, unsatisfied patient. These type of plate-like IOL are more difficult to be externalized into the bag because of their size, but with the gentle maneuvers, you can just externalize the IOL. The good thing in this IOL that they are hydrophilic IOL. It is easy to move them, and it is they are easily cut without the need of these special lens cutter. The problem with this IOL that you cannot counter pressure with a second instrument because they are malleable. They will fold with you. So you should hold it with the forceps and cut it into two halves, and then you can externalize this. Due to the length of the IOL, you should be very careful while externalizing the IOL not to harm the capsule. So you should put a second instrument under the IOL just to protect your capsule, and then after assuring the integrity of the capsule and the bag, you can implant another IOL. This is a patient in which he was implanted in a sensor, with a sensor IOL, which is more difficult to be cut compared to the Zeiss IOL. Here I want to show that you don't need to cut the IOL into two separate halves. You can just partially cut the IOL, and then you can externalize the whole IOL as a one unit. And this is very important in cases which you have a compromised capsule, in which there is a fear that when you externalize the first half, the second half may fall into the vitreous, so it is better to just remove it as a one unit. This is another example of a patient in which he had damage to the haptic while injecting the IOL. This is a Reiner IOL. So here you can do the same, just counter pressure and use your lens cutter, and you can cut the IOL into two halves, and then you can externalize the IOL through 2.2 to 2.4 millimeter incision. And after inspecting the eye post removal and making sure that everything is fine, you can just implant your other IOL into the bag, and then you can conclude the case. This is another case. This is very important. This is a case with a thickness which was implanted years after the patient. We should expand the IOL. And here, if you can notice, after injecting viscoelastic, there was an adhesion between the haptic of the IOL and the capsule and sulcus. And we advise at that stage not to manipulate much, not to harm the zonules. And as soon as you see this adhesion, you can just cut the haptic through the optic-haptic junction, and just you can leave the haptic over there and just remove the optic, and you can implant another IOL 90 degrees away from the first haptic. This is another case. It was referred to me. This is a PC IOL was implanted in the AC. It was an IQ IOL. So after cutting the IOL into two halves and externalizing the IOL, it is very important to inspect what do we have. You can see the corneal edema from the previous surgery. So when I inspected, I found that there is no enough support to implant an IOL in the bag, and there is a vitreous in the anterior chamber. That's why anterior vitrectomy was done. Limited anterior vitrectomy, and then after assuring that there is no vitreous in the anterior chamber, three-piece IOL was implanted in the sulcus. This shows the importance of having different type of IOL in the bench while you are doing your IOL exchange, because you may face these problems. So in conclusion, it is better to prevent or avoid doing such surgeries. Think of other options. Always know the IOL that you are dealing with, and be prepared with the proper instrumentation. And the most important thing is to know your limitation. Thank you.